Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is post-exposure prophylaxis for HIV, and the speaker is Dr. Archana ma'am. Dr. Archana ma'am is working as Assistant Professor with the Department of Medicine at Gandhi Medical College and Hospital, Hyderabad. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon to all. So today we are going to learn regarding post-exposure prophylaxis. Am I audible?
Oh, ma'am, you'll have to be a bit louder.
Okay. Very good afternoon to all. Am I audible now?
Yes, ma'am.
Yeah. Today we are going to discuss regarding the post-exposure prophylaxis guidelines.
Mallikarjun sir, please log out from the other system.
So the objectives of today's session is we are going to learn after the end of the session what is post-exposure prophylaxis and how much we are vulnerable occupationally to get transmitted, and how to evaluate a healthcare worker, and how do you prescribe the PEP and follow up after PEP. So healthcare providers, we are more prone for accidental exposure to the blood and other body fluids during our routine job work. So we are at risk of getting infected with HCV, HBV and HIV. So we are, in the sense, all healthcare personnel are risk of getting exposed to all these infections. So healthcare providers includes all the emergency care providers, lab personnel, nursing staff, interns, and autopsy personnel. Who all these persons are at risk of getting transmission of these infections. So here some of the definitions. So who is healthcare personnel? Healthcare personnel is a person who is paid or unpaid but working in a healthcare setting and who are at risk of getting exposed to the infectious material like blood and the body fluids, which are potentially risk of getting infection. And the exposure is the place where healthcare personnel is at risk of getting infection through the bloodborne infection. So occupational exposure is something where during our occupational job duties, performance of our occupational job duties, when we get exposed, it is called occupational exposure. Non-occupational exposure is something when outside the work environment, if we get exposed like unprotected sex or sexual assault. Needle stick injury is something which is injury by any sharp object. No need to be only needle. Any other sharp object will consider it as a needle stick injury, like glass vials, surgical blades, and forceps. Exposed person is the person who is at risk of acquiring the infection through exposing to the body and blood and other body fluids. The source person is from whom the infection is getting transmitted by his blood or his body fluids. So who are at risk? As we know, nursing staff, students, laboratory personnel, emergency care providers, interns, dentists, and mortuary staff, and who are handling with the waste material. All those are at risk of getting transmission. So here we have two scenarios that who is at more risk of getting infection. First scenario is healthcare worker during disposal of sharps from the ops gyno theater has a prick on his finger after a positive delivery. The second scenario is an internist had a splash of pleural fluid on his face from a HIV positive individual. So here we have two scenarios. We have to who is at more risk. Both are at risk, but who have a higher risk. That we will discuss in coming slides. So depending on the body, which body fluid we are getting exposed, the risk differs. If the body fluids are blood, semen, vaginal secretion, or cerebrospinal fluid, synovial fluid, pleural fluid, peritoneal, pericardial, and amniotic fluid, or any other body fluid which contaminated with the visible blood are has a more risk of transmission. But the body fluids like tears, sweat, urine, feces, saliva, and sputum and vomitus, unless they are contaminated with the visible blood, they are not at risk of getting transmission. So blood transfusion has a more risk of transmission rate is very high. Then we have a perinatal transmission has a more risk of transmission. Afterwards, sexual intercourse. So needle stick exposure has a 0.3%, which is the first scenario. Just we previously discussed in the slide. And the second scenario is mucous membrane splash, which has a 0.09% risk. So among those two scenarios, first scenario has a more risk of getting transmission than second scenario, because the transmission rate is more with the needle stick exposure. So the exposure risk, transmission risk depends on the type of the body fluid and the route of contact or exposure. So here is another scenario. A medical officer present to you emergency care for evaluation of needle stick injury 2 days ago while inserting an intravenous line to a HIV positive patient. Here they want to discuss you whether after 2 days is it necessary to give PEP and how effective it is. Can you start PEP in this situation? Starting the PEP, what is the risk of contacting HIV? Are the factors that might affect the risk? How effective is PEP? Is it too late to start PEP? What are the drawbacks of starting PEP? Which regimen should be considered and what follow-up should be arranged? What is the risk of contracting HIV? Depending on the type of exposure, you have a different rates of transmission risk. So, percutaneous injury is more with the HBV than compared with the HCV and HIV. So, HBV infection rate is more, that is 9 to 30% after percutaneous injury compared to HIV and HCV. The mucous membrane exposure, the infection rate of HIV is, transmission rate of HIV is 0.09%. So, depending on the depth of injury, the odds ratio is getting increased. That more deeper the injury, the transmission rate is more. And if there is a visible blood on a device, it is also more. If patient is terminally ill, that is his viral load is high, that is very sick, then also the transmission rate is high. So transmission rate again depends on the viral load of the particular patient, whether you are using the glove or not, whether you have used a hollow bore needle or a solid bore needle, and what are the environmental conditions. So large bore needle has a large bore needles weakly associated with increased risk. So more solid bore needle has less risk. Outside the environment, the virus usually doesn't survive. So how do you manage an exposed person? First, you have to go for a first aid, then you have to establish the eligibility, then counsel for PEP, then assess for the need of PEP, then evaluate the laboratory evaluation has to be done. Afterwards, you have to follow up the case. So management of the site, first aid. If it is a skin, better you wash the skin or exposed surface with water and soap. Do not scrub or do not use antiseptics. Do not use ethanol, chlorine, bleach or betadine, because they may cause a small abrasions through which the virus can enter the body. So after a splash of blood or body fluids, just thoroughly wash all the fluid and do not use antiseptic. If unbroken skin, wash with water. Do not use antiseptics. Eyes, thoroughly rinse the eyes with the water. Or else you sit on a chair and tilt your head on the back. So I'll ask your colleague to pour water onto your eyes or normal saline. If the patient is having the contact lens, better don't remove the contact lens. Thoroughly wash the eye, clean the eye. Then afterwards you can remove the lenses, because these lenses may act as a barrier for entry of the virus into the eyes. The mouth, thoroughly rinse the mouth with water repeatedly or several times. Don't use soap or disinfectants in the mouth. And consult a designated physician for the further management. Don't keep the finger into the mouth. So PEP must be initiated as soon as possible, preferably within 72 hours. Why the 72 hours? I will tell you the latter in coming slides. So first, assess the severity of exposure and the risk of transmission. Then assess the HIV status of the source person and assessment of the exposed individual also. So categories of exposure, the exposures we can categorize as mild, moderate, and severe exposure. If exposure of the mucous membrane or a non-intact skin with a small bore needle or small volumes, you can consider it as a mild exposure. If exposure to the mucous membrane with a large volume or a percutaneous superficial exposure with a solid needle, it is a moderate exposure. Percutaneous exposure with a large volume, an accident with high caliber, a deep wound, an accident with a material that has previously been used intravenously or intraartificially.
Excuse me, ma'am. Hello. Ma'am? Ma'am, you'll have to speak a bit louder.
It's better to use a headphone.
Okay. Source of HIV, is it okay? Hello?
Ma'am, your voice is not coming. Participants are requested to kindly bear with us. No, ma'am. Can you try logging again? You have put some headphones or something?
Hello.
Yes, ma'am. We can hear you, but the voice is too low.
Hello.
Yeah, ma'am.
Is it okay now?
Yes, ma'am. Please continue.
Okay.
Requesting all the participants to please increase the volume on their systems. Ma'am, please continue.
Okay. And the situations also depends on the results of the source. Like if it is negative, HIV negative, source is HIV negative, and you can still think of other viral infections like HPV and HCV. If patient is HIV positive, source is HIV positive and clinically asymptomatic, you can consider it as a low risk status. And if patient is source person is HIV positive and clinically symptomatic, you can consider it as high risk. So before starting a PEP, please take the informed consent. Explain regarding the PEP, risk and benefits. It should be clear that PEP is not mandatory. And you should also give the information regarding the window period, baseline tests, safety and efficacy of the drugs you are using. And also give psychological support, because whenever a person getting exposed, the first thing he will have is a very panic, will get anxiety. So better you give a psychological support in case. And other things is documentation and record is essential. Special leave from work may be considered. Recording and reporting framework as per the NACO guidelines. Next, deciding on PEP regimen, availability and prescription of PEP and vaccination for hepatitis B. So assessing the need for PEP and prescribing the PEP. In case of sexual assault, PEP should be given to the exposed person as a part of overall package of other assault care. Okay. And if the source person is already an ARV, it doesn't change the regimen of PEP. So if a patient is known source, better do consider him for a rapid antibody test. Don't go for a direct virus assess. We routinely don't do. We usually do rapid antibody test. If sources are not known, don't test the discarded needles or a bloodborne pathogens for testing. If it is remain, depending on the prevalence of that particular area and depending on his high risk behavior or his symptoms, we can decide whether to give or not to give PEP. This is when the source status is not known. When should PEP be started? So PEP should be started as soon as possible, because as the time goes on, the benefits of PEP are getting decreased. You can see the graph that the efficacy and benefits are decreasing trend. So why 72 hours? This slide explains why 72 hours, because whenever the patient exposed to the HIV virus, that will enter into the mucosal surface, and through the dendritic cell, it is carried to the lymph node where the virus replication occurs and it released into the blood. So where the primary viremia occurs. So our idea of giving PEP in 72 hours is to give before the viremia. Before the viremia occurs, we have to start the PEP. So animal model studies and some of the studies suggest that less effective beyond 24 to 36 hours. Better to give within 4 hours. So here, duration of the PEP. The slide explains that the blue color indicates the PEP has given for 28 days, where the transmission is 0%. Here the red color, the PEP has given for 10 days and the transmission is 25%. That is zero conversion, nothing but. And for 3 days, it is 50%. So better to give 28 days of PEP. So 28 days is more effective than the 10 days or 3 days. So PEP should be started within 72 hours of exposure. If patient present to the present to you after 72 hours, PEP still be given, but you have to give the counseling regarding the efficacy. It should be made available all emergency departments, labor rooms, intensive care units, and operation theaters. The exposure person should go to the designated clinic or office as early as possible. And he should complete the risk assessment, counseling, testing, and go for a PEP. And all staff members must know whom to report for the PEP and where the PEP drugs are available. When to obtain an expert opinion. When there is a delay after 72 hours or the source is unknown, whether to start a PEP or not, to decide. And the source patient is already an ART and possibly he might be having drug resistance. And if the major toxicity of PEP regimen and patient has a severe psychological problems, better to consult an expert. are referred. So here we have two codes like exposure code and source codes. Depending on that, the how much is the risk and how to start PEP or not, we will decide. So exposure codes are we can see when the material is blood, bloody fluid, and other potentially infected material or instrument contaminated with one of these substances, then you consider it as S. If these things are not there, then PEP is not required. If it is there, then exposure, what type of exposure is there? If it is a mucous membrane or a skin integrity is compromised, then you categorize small volume or large volume, few drops for short duration or a major volume splash for long duration. Depending on that, if small volume and short duration, you consider it as exposure code 1. If large volume and major splash for long duration, you consider it as exposure 2. If the skin is intact, no PEP is required. If there is a percutaneous injury, you have to decide the severity. If it is less severe, solid needle is used and superficial scratch, you consider it as a exposure code 2. More severe exposure, hollow bore needle or a deep injury, consider it as a exposure 3. The source codes, if patient is HIV negative, source person is HIV negative, PEP is not required. If source person is HIV positive, you divide them into low titer exposure, asymptomatic person, or a high CD4 count, you consider him as a HIV source 1. If patient is a high titer exposure, advanced disease, and low CD4 count, you consider him as a HIV source code 2. So as the patient has more viral, source has a more viral load or advanced disease, chances of transmission are more. If patient's source of HIV status, source person's HIV status is unknown, you consider it as HIV source unknown. Better you start PEP. So depending on the exposure code and source code, we divide them into, if both the things are one, there is no need to start PEP. But any of them is more than one, better to start PEP. And if source code is unknown, consider PEP. And PEP should be given for 28 days. And you have to calculate the prevalence of the HIV in that particular area when source is unknown, HIV status is unknown. And depending on that, you can categorize and start the PEP. If it is high prevalent area, more risk of transmission, then you can start directly PEP. So what are the recommended regimens? Usually for adults who is more than 10 years and more than 30 kg weight loss, you should give tenofovir, lamivudine and dolutegravir, 300 mg, 300 mg and 50 mg. Alternative regimens, if instead of dolutegravir, you can use lopinavir, ritonavir, or instead of lopinavir, ritonavir, efavirenz can be used if there is any contraindications or unavailability of the particular drug. If children is more than 6 years and age more than 20 kgs, the recommended regimen is zidovudine plus lamivudine plus dolutegravir. But if the exposure person's HB is less than 9, then give abacavir in place of zidovudine. If children is less than 6 years and age is less than 20 kg, give zidovudine, lamivudine and lopinavir, ritonavir instead of dolutegravir. If his HB is less than 9, give abacavir in place of zidovudine. So the first dose should be administered immediately within 2 hours, preferably within 72 hours of exposure. And he should be counseled and duration regarding the duration, and duration must be the 28 days. So whatever the PEP regimen we are giving, the duration is 28 days. So you can have a side effects with the PEP regimen as any other drugs will have. So the mild symptoms can be given symptomatic treatment like nausea. Symptomatic treatment is enough. Headache, efavirenz can cause headache. Up to 2 weeks you can wait. If it is more than 2 weeks, take an expert opinion. Diarrhea, treat symptomatically. Up to 2 weeks, it's okay. If it is more than 2 weeks, then further follow-up or evaluation is necessary. Fatigue is usually for 4 to 6 weeks. He can take sick leave, but if it is lasting more than 6 weeks, better to call for advice or refer the patient. If patient has any CNS side effects like anxiety, nightmare, psychosis, and depression, those are common with the fever range, should be treated. If it is less than 3 weeks duration, you can treat symptomatic treatment you can give, but it's lasting more than 3 weeks, better to take a expert opinion. If patient is under severe depression or patient has a self-harming behavior or a suicidal tendencies, better to refer the patient. If patient has a rash, if patient is on a fever range, carefully examine for rash and take an expert opinion. Fever, look for any other infections. Is it, and look whether it is a acute HIV infection or any acute hepatitis is there, or any non-HIV related infections. First evaluate and treat accordingly. If patient has a jaundice or abdominal pain, stop the drugs and take an expert opinion. So HBV vaccination after accidental exposure to the blood. So usually for HBV infection, post-exposure prophylaxis vaccination is recommended. So if the exposed person is not vaccinated previously, give complete dose of hepatitis B vaccine. If he is vaccinated but his anti-HBs status is not known, then give a booster dose. And vaccinated for more than 5 years ago, then give a booster dose. Please don't wait for anti-HBs antibody levels. If you don't know the anti-HBs antibody levels, better to give a booster dose. And recommended anti-HBs antibody levels is more than 10. So what investigation has to be done for the person? So before taking PEP, better you give a baseline HIV, go for a baseline HIV, HCV, anti-HBsAg antibody level, CBP and serum transaminases. Even if the person is not taking PEP, go check for HIV, HCV and anti-HBsAg antibody levels. Within 6 days is recommended. So, even after giving PEP or not giving PEP, better to you counsel the person regarding repeat testing of HIV, HBsAg and HCV at 6, 12 and 24 weeks after exposure. Whether or not PEP has been started, follow-up is indicated to monitor. So you have to check for the patient whether HIV seroconversion has occurred or not. Whether patient is having a fever, any generalized lymphadenopathy, any eruptions, pharyngitis, any non-specific fluids, flu symptoms, or oral or genital ulcers. So most of 50 to 70% of the patients will have an acute HIV infection within 3 to 6 weeks after exposure. So clinical monitoring, you will monitor for acute seroconversion within 3 to 6 weeks. And during this period, better you avoid breastfeeding, you avoid blood donation, and pregnancy should be avoided. And during sexual relationship, better use protective measures. And adherence and adverse drug reaction. Regarding adherence and regarding adverse drug reactions, better counsel. So when to do laboratory evaluation? Within 2 to 4 weeks, better you do a complete blood counts and FBS, PLBS and serum creatinine levels. And at 6 weeks, 12 weeks and 24 weeks, better you repeat a HIV antibody test. So here, when a exposed person comes to you, first you assess, you will establish his criteria, eligibility criteria. You will do the HIV testing and provision of first aid. Then you will counsel regarding the risk of HIV, risk and benefits of PEP and side effects. After that, you will prescribe a PEP. Better prescribe as soon as possible, and it should be prescribed for 28 days. And afterwards, you have to follow up you have to assess the underlying comorbid conditions, drug-drug interactions, and HIV antibody testing should be done at 6 weeks, 3 months, and 6 months after exposure. How do you prevent the exposure to and transmission of HIV and other viruses? So, depending on what is the technique through which the transmission has occurred, during the procedure are more risk of getting transmission. During the use, 52% is the risk. And in between, if it is a multitask process, between the steps also we have a more risk. Okay. And which type of needles, which type of material also determines the risk of transmission. So suture needles have a more risk of transmission. Then we have a disposable syringes have a more, and other things 31% of risk. So you should be very precautious while recapping the needles. Better you avoid recapping the needles and transferring the body fluids between the containers. Very precautious during handling and passing the needles or sharp objects, and proper disposal of needles and proper health care waste management has to be done. So better to avoid recapping of the needles. So practices that should reduce the risk of occupational exposure is, you should be strict compliance to the standard workplace precautions. Better to avoid injectables, better to give oral drugs, better to avoid recapping needles, promptly dispose the needles and sharp objects. Immediately report after needle stick injury or any sharp related injuries, and better participate in trainings related to the infection preventions. Use devices which have a safety precautions, safety things, and better record and monitor the injuries in injury register in each location at healthcare setting. So standard precautions uh, are intended to prevent the transmission in the exposure of healthcare workers and patients. So standard precautions, what are they include is hand wash should be done before and after of any medical procedure, and safety handling of the sharp needles, and using the special containers for the sharp disposals like vacuumators. Safe decontamination of the instrument should be done using the protective barriers like gloves, mask, and googles and aprons, boots, and safety disposal of the medical procedure. Better use a glove, uh, mask, and universal precautions, safety handling of the sharp instruments, and using the needle destroyers.
Thank you so much, ma'am. Any questions from the participants? They can unmute their mic now. Please feel free to write in the chat box. Any questions regarding PEP from the participants?
Hello, madam.
Yes, ma'am.
Madam, PEP is universal, no, madam. You can give to everyone, no? Whoever is that, whoever has been exposed to
Yeah. Yes, ma'am.
people from private or government. Is there anything like that?
PEP, you can give to PEP any person who is exposed to the who is exposed and who is risk of getting transmission, whether he is working under private conditions or public conditions.
Okay, okay, thank you.
Government setup, I mean.
Any more questions from the participants? Kiran sir, can we quickly run the feedback form, please? The feedback poll is now visible on your screen. All the participants are requested to quickly answer the feedback poll. There are 4 questions in all. If there are any questions on the PEP, please feel free to put in the chat box or you can unmute your mic.
Madam, after 72 hours, we can give PEP, no, madam?
You can give PEP after 72 hours, but you have to explain the person regarding the efficacy of the PEP. As we have shown in the one slide that as the times goes on, the benefits of PEP are getting decreased. Yes.
Many cases like which after 72 hours PEP has been given and it has been effective, that any cases are there, madam?
There are studies that after 72 hours of after prescribed period of PEP given, that the infection rate, seroconversion is more compared to less than 72 hours.
Participants are requested to please fill in the feedback poll. Thank you so much, Archana ma'am, for facilitating this session.
Thank you.
Thank you to all the participants for patient listening. Kiran sir, we can end the feedback poll now. Ma'am, we'll conclude the session now. Thank you so much.
Thank you, ma'am.
Questions